Yes. All good?
Yeah.
Yeah. All right. Assalamu alaikum, everyone, and a very warm welcome to you all. On behalf of Imamia Medics International UK chapter and Al Sadiq Virtual University, it's my great pleasure to welcome you to today's joint online webinar. Thank you for joining us for this academic session titled Overview of Cellular Therapies. This webinar is part of our ongoing commitment to promoting high-quality medical education, fostering academic collaboration, and keeping healthcare professionals updated with advances in modern medicine. Today, we are honored to have with us an esteemed guest speaker, consultant hematologist Dr. Hussain Janan. It is my privilege to introduce Dr. Hussain, who works at Portsmouth Hospital University NHS Trust. Dr. Janan is a highly experienced clinician specializing in the diagnosis and management of both malignant and non-malignant hematological disorders. His key clinical interests include cellular therapies, stem cell transplantation, and advanced treatments for blood cancer. In addition to his clinical work, Dr. Janan is actively involved in clinical research, multidisciplinary patient care, and medical education. Through his contributions, he continues to play an important role in improving patient outcomes in hematology and advancing the integration of innovative cellular therapies into routine clinical practice. We are truly grateful to Dr. Janan for taking the time to share his expertise with us today. Without further delay, I would like to invite Dr. Hussain to begin his talk on cellular therapies. Over to you, Dr. Hussain.
Thank you, Dr. Qurat. Assalamu alaikum to all, and thanks for inviting me to this occasion. And I'm really grateful to all of you. And I don't really know the audience, like I think so it's mostly medics, what I gather. So can you guys see my slides?
Yes, we can.
Yeah, we can.
Okay, fine. Yeah, so today our topic is overview of cellular therapies. So I kept it slightly generalized because if it goes too specialized, it might not be much interesting to many of the audience. So starting with the cellular therapies, looking previously like we're having the chemotherapies and then moving towards the targeted therapies, and also the cellular therapies treating patients with their own cells. So there are different forms of cellular therapies. So today I'll be discussing mostly, it will be the CAR T therapy. These are the T lymphocytes, T cells. And we'll be talking about allogeneic stem cell transplant. So, and then the next one will be the donor lymphocyte infusions. I will go in depth once we go through each of those. So CAR T cell therapy, CAR T cells, they are the lymphocytes, T lymphocytes, in which we give that, we individualize the therapy, rather we call it personalized therapies. And because we treat the patients with their own T cells, and that require a lot of like sophisticated management and very sophisticated process. And I will go through that one by one. So normally what happens, because in our body, we can have, the cancer cells can grow anytime, but our T lymphocytes are programmed in such a way that it identifies the cancer cells and it kills the cells. I don't know if you can see my cursor.
Yes, we can.
Yeah. So these are the T cells, and then what happens when the cancer cell, start, any cancer cells appears in the body, because those cancer cells produce antigens or proteins on the cell surface, and those are identified by the T cells, and the T cells kills those cancer cells. That's why we don't develop cancers usually. So what happens when the T cells, the T lymphocytes, they fail to identify the antigens on the surface of the cancer cells, and that is the case that the cancer cells grows then. So I don't know if you guys with me now until here. So the normally T cells identify the cancer cells, but when they can't identify the cancer cells, then the cancer cells can proliferate, and that's how we diagnose the cancers there. And so what we do in CAR T therapy then? So because T cells here is unable to identify the cancer cells, so we are going to teach the T cell how to identify the cancer cell and go for it. So first of all, so this is how we generate the T cells. So we take the T lymphocytes, and then through the lenti or retroviral vector, so these are inactivated viruses which are given, and by that way the T cells produces antigen on the surface, and that antigen is called chimeric antigen receptor. That's why it is named as CAR T therapy. So CAR is for the receptor, NT or the T cells. So the T cells who were lacking receptors and were unable to identify the cancer cells, now by the help of this viral vector, we designed in such a way that the T cells produce the receptors on the surface, and it will identify the cancer cells now. Yeah, so you can see here by this animation cartoon, and it's having a lot of receptors here. So how they are engineered, how we make those T cells who are lacking receptors, who are lacking those sensors. So first of all, we collect the T cells from the patient. And secondly, we modify it to express those antigens on the surface. And then the third step is we expand it, we proliferate it further so we can have a good number of cells. And then we reinfuse that to the patient, and that will target the cancer cells then. So if you see the process here, so how they are manufactured, first of all, we apheresis the patient. We took the the lymphocytes, and which are sent to the lab, and then we do the manipulation of the T lymphocytes so that they can express the CAR antigens on the surface. And then we do the CAR T cell expansion. And once those cells are ready, they are shipped back to the hospitals, and where those are infused to the patients after giving them some chemotherapy, which is called lymphodepletion chemotherapy. And after that, we infuse the cells. And once those cells are in the body, so now these cells are wise enough, and they are identifying the cells, the tumor cells, and they target only the tumor cells. They don't target the rest of the body. So they are meant targeted because they are targeted. And now when they are in the body, they identify that this cell is not, this tumor cell is not normal. So they go and attack them and kill them. So what are the conditions where we can give CAR T cell therapy? So I'm based in UK, so I think I will go with the nice approvals. So it is approved for some of the conditions. Mostly it's lymphomas, and also for ALLs as well, acute lymphoblastic leukemia. And then in the lymphomas, we have different lymphomas like DLBCL. We have mantle cell lymphoma, and also for follicular lymphomas. So given in those conditions, these are the indications for using the CAR T cells. So these are the hematology indications, actually. So now a lot of trials are going on, and why it is important for all the other specialties, because now these CAR T cells, or these living cells with which we treat the patients, we call cellular therapies. So they're going to the other specialties as well. So there are many conditions which are not treatable or which are refractory to the treatments and those specialties. And they are also receiving CAR T cells now, but they are on trial basis. But soon they're going to come into those specialties, like some rheumatological and autoimmune conditions, like you can have SLE and a few others, which I will go in the next slide, I'll show you. And then some neurological conditions and some solid tumors as well. So it is no more like only hematology. It is going to many other specialties where we'll be treating the patients with the living cells. So this is where we are ending into this new era. Then coming, which autoimmune conditions are potentially treatable with the CAR T cells? So vasculitis, autoimmune encephalitis, and CIDP, neuromyelitis optica, refractory autoimmune hemolytic anemia, ITPs, GVHDs, POEM syndrome, inflammatory bowel disease, pemphigus vulgaris, so myasthenia gravis, SLE. So it's going a lot into those areas. And so this topic has been, the specialities or different specialities, different specialists are really interested in those CAR T cells, because if we will start treating those conditions like neurological, autoimmune, or rheumatological, so they need to know it, like what the CAR T cells are, how they function, how to look for their side effects in long term. So they need to know it. So uh, you might be from different specialities, but these cellular therapies are getting there. Then going to the toxicities, the side effects. So I will not go in the detail because there is a lot to go into it, but I think so just for the sake of overview, I will just name it. We call cytokine release syndrome, which is usually like with the fever, hypoxia, and so that's and low blood pressure. And then coming to the ICANS, which is like neurotoxicity, that can be in the form of seizures, confusions, even their handwriting goes funny. And coming to the neutropenic fever, sepsis, and tumor lysis syndrome, cytopenias, low counts, and then B cell aplasia. Am I going too fast or too slow? Can you? Hello?
It's perfect. It's perfect.
Thank you. So then going to the allogenic stem cell transplant. So because as we are discussing about all the different cellular therapies, stem cells are also cells. So and I'm specifically discussing allogenic transplant, not autologous one, because autologous, we use our own stem cells and give it back to the patient. So that is autologous. And then allogenic, we need a donor for that to get the stem cells from the donor and infuse those donor cells. Why we do allogenic in some cases, do autologous in some of the cases. If the problem is starting from stem cell, then we will go for allogenic because it can't be corrected without donor stem cells. And if problem is not in the stem cell, it is down the line somewhere, like for example, plasma cells, for example, some of the lymphocytes, like some lymphoma cases, where we can offer them autologous stem cell transplant. So let's go to the allogenic stem cell transplant. So I will just quickly go through the process, and then we discuss a bit of each bit from those headings. First of all, indications where we do those. Patient eligibility, donor selection, so there should be a donor, and harvesting from the donor. So we get those cells by apheresis, and then conditioning chemo. So the patient should be ready for the stem cell. So we give them some conditioning chemo, followed by stem cell infusion, and then we monitor them for the different complications and engraftment monitoring. And then these patients need long-term follow-ups. So first of all, the indications. So allogenic transplant is mainly used to treat hematological cancers and certain non-malignant disorders. Like hematological conditions I mentioned, acute myeloid leukemia, ALLs and CMLs and different conditions. But mentioning the non-malignant one, so the non-malignant, like we have sickle cell disease patient, if they are having loads of transfusions and they have developed multiple antibodies and they can't cope with that many transfusions, so then allogenic transplant can be offered. And then coming to the patient eligibility factors, so which can be different things, disease status, other medical conditions of the patient, and overall fitness of the patient. So usually if the patient goes above 70, it is hard to transplant them. Then And also if they have very bad kidneys or very bad heart disease, like heart failure, for example, ejection fraction very low, it's difficult to transplant them. So these are the different factors we look at before going to transplant those patients. And so next is donor selection and stem cell harvesting. So first of all, when we identified that this patient needs the stem cell transplant, and then the next thing is we have to select the donor for that patient, and we do the HLA typing and look for the best match to the recipient, so that they can to avoid complications later on with the best match. So that depends mostly on the HLA typing, but it can be other factors as well, like CMV or blood group, age of the patient. So these are the different things which help us in the donor selection. Usually, so donors are younger than 35 years. So try to go for the younger stem cells. And then stem cell harvesting. So this harvesting can be from different sources. Like one is the bone marrow, other is peripheral blood, third is umbilical cord. The commonly used is the peripheral blood. How we use the peripheral blood? We give them some growth factors and bring the stem cells into the blood, and from blood we freeze them and collect them. Previously, bone marrow were used, and also in some centers still umbilical cord transplants are done. Like Manchester is one of the example where they MRI, that's the Manchester Royal Infirmary, where they do the cord transplant. So the cord transplant is more complicated than the peripheral blood and others. So we select the donor based on those criteria. Then we took the stem cells from the donor. Next is we start preparing the patient by giving them conditioning chemotherapy. So why we give the conditioning chemotherapy? Sorry. Okay. So we give the conditioning chemotherapy. The conditioning chemotherapy is given to the patient so that we remove all the stem cells from the bone marrow. It just clearly wipe out the bone marrow. And also it makes spaces there so that when we are giving stem cells, those stem cells can go there and make nests there and start producing cells from there. So after the conditioning chemotherapy, few days later, we give them that donor cell infusion, the stem cells which we have taken from the donor.
P20.
No, P20.
Yeah. So we give them those donor cells. And after giving the donor cells, we monitor the patient for a few things. One is engraftment, just like when we put a graft in the tree. So exactly like, because we give them the stem cells and we were waiting for it once it engrafts, and there are different indicators how we know this is engrafted. So we have criteria for it, like when we have neutrophils above 0.5 for a couple of days. So we think, okay, this is engrafted. So these are the indicators, because the stem cells already started producing their own cells now. And also what happens if patient receive donor cells which are a different blood group, so what will happen by the end of the transplant, the patient blood group will become the donor blood group. For example, if the recipient is blood group B and received cells from the donor who is blood group A, that patient will become blood group A. Then going to the complications. So there are multiple complications. I'm not going into each one of those, just the major ones. Neutropenic sepsis is quite common. Graft versus host disease. VOD, we call veno-occlusive disease. And viral reactivations, if someone's have a previous history of CMVs, EBVs, and the other viruses, those can be reactivated. Graft failure, it's possible we give them the stem cells and it might fail. And long-term complications include endocrine dysfunctions, which can include different endocrine organs. So whole this process normally takes if less complications, and in that case patient usually stays like 40 days in the hospital, 40 to 50 days, and after that, once the patient is discharged, patient is followed up twice a week for first few months till day 100, and after that they are followed once a week, and then by the end of 1 year we increase this interval. And also that is the time we think about revaccinating them. So because they have got a new immunity now, they have lost their own immunity which they develop over the time, and because now they have got different immune system that needs to be immunized. So we immunize them usually after 1 year. I'm not going into the details of that criteria and everything, otherwise it becomes too complicated. So the long-term complications, so we run clinics called late effect clinics. So especially this GVHD, graft versus host disease, it can affect any organ, eyes, lungs, joints, anything it can involve. So we monitor them, and that is we initially start few months, and then we yearly see those patients after the first couple of years. And after the stem cell, we always, in the late effect clinic, monitor for any relapse if the disease is coming back or developing of new cancer. So we monitor for those things. And also the quality of life concerns we address in that clinic. Coming to the donor lymphocyte infusions, I put it here because it is related to allogenic transplant. So why, when we use them? So what happens when we give stem cells from the donor and we wait for engraftment in the patient? So if patient engrafts, well and good, and then continues and it's working well. But a time when we feel that it is becoming weaker or the disease might relapse, so that time we think, okay, now this stem cell has got weakened, or so in that case we give them donor lymphocytes. So these lymphocytes are taken from the same donor who has donated the stem cells. What these lymphocytes do, so when these lymphocytes, we infuse them, they support their own stem cells, because the stem cells which are already present there, although they're weakened, but they're still there. So we give them these donor lymphocytes. They go and support their own stem cells against the body. So when they have those lymphocytes, so the stem cells has the time to proliferate and start working again. So as I discussed earlier, so it's the process of infusing donor lymphocytes to boost the immune system after transplant. And it is only in the cases when we see the patient is relapsing with the disease, we try to give them and try to avoid second transplant. So these donor lymphocytes usually helps. And the benefit is, as we said, so immune surveillance to induce remission in the patients to control the disease. And associated risks include GVHD, graft versus host disease. And then we need carefully monitoring the patient. So in the summary, if I say CAR T cells or the T lymphocytes, which are engineered and they target the cancers only. And in UK, they are approved for relapsed and refractory B-cell malignancies and ALLs. The indications are not limited there. Other indications which will be coming soon in near future: autoimmune condition, neurological diseases, so solid organs as well, solid organ cancers, and toxicities, common one, major one, CRS, ICANS, and cytopenias. And coming to the allogenic transplant, those are the donor stem cell replace disease marrow and treat the blood cancers and non-malignant disorders, which we already discussed. We do the HLA matching for the donor selection, giving some conditioning chemotherapy before giving the cells to the patient, so that bone marrow is wiped out of the recipient cells and can have donor cells. And then the risks include GVHD infection and graft failure. Coming to the DLIs, these are donor lymphocyte infusions. So post-transplant immune boost. So it helps its own stem cells, as I discussed earlier. So these are the donor lymphocytes, which help its own stem cells, which are infused to the recipient. And the risks, major risk is GVHD with that case as well. Conclusion, cellular therapies are revolutionizing treatment for high-risk hematologic diseases with growing applications beyond oncology. Safe implementation requires expert management of toxicities and long-term follow-ups. I don't know, I did too quickly or?
No, thank you so much.
Thanks.
Thank you so much, Dr. Hussain. Janan, before we move to the Q&A, I would like to sincerely thank you for delivering such an excellent and insightful webinar. It's interesting that you began by explaining the CAR T cell therapy, covering the principles of T cell engineering and the manufacturing and production process of CARs. You then discussed the clinical indications where CAR T cell therapy is effective, particularly in hematological malignancies and emerging applications in autoimmune diseases. Key toxicities of CAR T cell therapy were highlighted, including their risk, early recognition, and management strategies. Dr. Janan provided valuable insights into allogenic cellular therapies, focusing on indications, patient selection criteria, and appropriate timings. He clearly explained the donor selection process, stem cell harvesting, transplantation procedures, and the critical phase of engraftment. The session also covered the donor lymphocyte infusion, including its indication, potential benefits in disease control, associated risks such as graft versus host disease, and expected clinical outcomes. Important complications of cellular therapies were discussed, followed by an overview of long-term outcomes, survivorship, and quality of life. Once again, thank you so much, Dr. Hussain Janan, for sharing your expertise and making this advanced topic accessible and clinically meaningful. We will now open the floor for questions and discussions.
Thank you. Thank you for listening.
Yes, please. Anyone, please unmute yourself and you can ask questions directly, or you can put it on the chat and we can ask for you.
So let me begin, Qurat. Excellent talks, Dr. Shabeeh. So it's an excellent talk and something which is fascinating not only for clinicians, but also non-clinicians, those who are in research, for example, people who are doing basic research, because these precision medicines and targeted therapies is a new field. It's the horizon, it's changing in terms of medical. I have just one question. This run to disease is the same as graft versus host reaction? And if so, how often do you see it in your practice?
Sorry, can you repeat again? So what specifically about GVHD, yeah?
No, I'm just talking, graft versus host reaction. Is it the same as it was called the Hunt's disease or Hunt's reaction in olden days?
I have no idea about Hunt's disease.
Okay.
Because graft versus host disease, what happens normally is like, because these stem cells, they are foreign, and especially in allogenic transplant, not in CAR T cells or their own cells, patient own cells. And and the transplant, because when the donor cells comes and the body identifies it, so the body cells, the T lymphocytes in the recipient, they fight against those cells. And specifically what happens when we give stem cells, so there is always chance of some lymphocyte from the donor also goes to the recipient body. The recipient body is already weak enough because we give them such a strong conditioning chemotherapy that we have wiped out their immune system. We have wiped out their whole bone marrow. There is nothing there. So, and when these cells goes there, they think, okay, this is our own body. So this belongs to us. Although they are foreign, they are not from the body. So the lymphocytes which go there, they start growing and they start attacking the body as well. So because they think this belongs to us, and the rest, whatever is foreign, they start attacking them. and they start treating the recipient body as like foreign to them. And so it's a difficult balance. Usually what we do, we give them a lot of immunosuppressants and we control this thing so that they will not develop severe GVHD. Although we think some of GVHD is good, we want to have some very mild form of GVHD, but we don't want to have severe GVHD. So yeah, that's the
Thank you. So my question continues in terms of the response and the reaction. In my previous life, I was a head and neck surgeon. I did a lot of cancer work. And one of the problems that we faced was that in these extensive tumors like oral carcinoma, squamous cell carcinoma in particular, which is very aggressive, as you know, when you give them immunotherapy or chemotherapy or radiation combined with chemotherapy, their immunity would fall. And that's exactly what you're doing. You're trying to deprive the host of the immunity.
Yeah.
What we notice, it's a very common practice in India and Pakistan and the Middle East, where you see these patients, they develop extensive fungal infections like rhinocerebral mucormycosis and cephalic aspergillosis, which by itself became a nuisance because neither could you treat the tumor nor could you treat the fungus. So they had dual pathology at the time. Have you encountered any cases of fungal infections post-op?
So actually, we think fungal infections are more contributed to the prolonged neutropenia because these patients are not having neutrophils for ages, because when we give them wipeout and for prolonged period, they're not having neutrophils. So that's one of the main thing they develop fungal infections. Yeah, GVHD is totally a different process. That's more like graft versus host effect. But we often see those patients with the fungal infection, severe fungal pneumonias. And as I mentioned, neutropenic sepsis, but I didn't go into the further detail. And it's, fungal pneumonias are common. PCPs are common. We give them antifungal prophylaxis and we give them antibiotics till they recover their neutrophils, because they will need, as I said, we need to prevent the bacterial infection. We need to prevent the fungal infections. And as far as the PCP prophylaxis is concerned, we can't give them cotrimoxazole, which is quite myelosuppressive, because if we give them, that might affect the stem cells and might not be able to engraft well. So what we do normally in those patients, we give them pentamidine nebulizer. So that is given every 28 days. By the time they have developed engraftment, they have engrafted, and they have their own neutrophils. So we give them this pentamidine nebulizer before we discharge them, and we continue this for 2-3 months. So once we feel they're okay, then we start cotrimoxazole, although which is myelosuppressive, but by that time they have enough cells and they can tolerate it.
Thank you so much.
Thank you so much, Dr. Hussain. There's a question posted on the chat. Can you explain the difference between harvesting SCs from adipose tissue versus BM? Which one is viable and recommended after 40?
Sorry, what was it? Can you let me check?
If you can unmute Brother Hadi, Baha Aldin Hadi, you can ask the question directly if you want. Yes, please.
Yes. Thank you very much, dear Dr. Hussain, for your kind, very informative lecture, and really appreciate your kind effort. I have one question regarding the harvesting technique and the type for the stem cells. Which one you prefer regarding the extraction of the cells from the adipose tissue or bone marrow after 40 years?
So as I discussed, there are different type of transplants we do, which include bone marrow transplant, peripheral stem cells, and third was the cord one, umbilical cord. So the common these days is peripheral blood one. So why we prefer that one? That is much safer and much easier to do it. So we give them GCSF, which is also called filgrastim. These are the growth factors. We give them those injections. So what it do, it makes the stem cells, they come from the bone marrow to the peripheral blood. So when they migrate there because of those injections, that is the time we apheresis them. We put them on the apheresis machine, just like when you see someone in the dialysis. So in the same way, we take the stem cells from the donors by that way. That is one way. The cord one is a complicated process. We don't normally do it. It's done in very specialized centers, even in the UK. It's not in many. I think so. We have a couple, 2-3 centers who are doing this umbilical cord ones. So normally, as I said, with the growth factor injections, we mobilize the stem cells, bring it to the peripheral blood, and from there we freeze it and then infuse it to the recipient. But before that, we need to store it. So the stem cell directory, the donor directory, is quite extensive here in the Europe. And the donors, like someone who will need transplant in the UK, so the donor stem cells might come from Germany. It might come from other European country, because they register themselves. The donors are all over the Europe, and it's because of that reason it is easy to find a good match for the white population, because there are many donors in the white population. Unfortunately, and the rest of population, we don't have many donors. When anyone among us, when we get sick, we get such conditions, and then finding a good match is really difficult thing.
Okay, so the autologous you prepare rather than allogenic type?
Now, so as I said, if the problem is in the stem cells, like for example AMLs, ALLs, and then they will need stem cells from someone else. If the problem is not in the stem cell, is down the line, for example, in the plasma cells, which is in myelomas, or lymphocytes, which are in lymphomas, so then the stem cells are okay. So what normally we do, we take the stem cells from the same patient and store it, and then we give them strong chemotherapy to wipe out their bone marrow. So down the line, because the problem is down the line, not exactly up on the stem cell, and we give them back those stem cells. So it is no more called transplant now, although the terminology is still used, but we rather call it stem cell rescue.
Okay, thank you.
Yeah.
Perfect. Any other questions? Looks like it was, mashallah, very self-explanatory. So we're just gonna, inshallah, on behalf of Imamia Medics International UK chapter and Al Saadiq Virtual University, we would like to extend our sincere thanks to Dr. Hussain Janan for generously sharing his time, knowledge, and expertise with us today. We're also grateful to all our attendees for their active participation and engagement throughout the session. This brings us to the end of today's IMIS-EU joint webinar. We hope you found the discussion on cellular therapies informative and clinically valuable. Thank you once again for joining us, and we look forward to welcoming you to our future educational events. Many thanks, Dr. Hussain.
Thank you, Dr. Qurat, and thanks everyone for listening, and thanks for inviting me to IMI. I'm really grateful.
Thank you so much.
Thank you.
Allah Hafiz.
Allah Hafiz.